This is our time for question and answer, so hopefully you've got a big stack of them. We also want to welcome at this time Dr. Mary Jean Schumann, who is going to help facilitate discussion as we move forward for the next hour. And then following that, we're going to have a presentation by Dr. Janice Smith on pediatric residency, because we actually collected some information on our survey about faculty perceptions about pediatric nurse residency programs. So without further delay, Dr. Mary Jean Schumann, please take us through this question and answer period. Thank you.
Okay, so thank you very much. I am going to give you, first of all, a 2-minute summary of what I think we heard in the last hour to see if I capture the really high points. But then I will have a question for each of the panelists, the same question, and then we'll have them answer all of your questions from every which corner of this conversation. So we've heard, first of all, from Dr. Vessey about the historical paths that were taken, the divergent paths, and I think given the conversation this morning, it was particularly refreshing for me to hear what the roots of that public health path were, because clearly we all, I think, had lots of conversation about that this morning, but lo and behold, that really was a path that was being undertaken even in the 1800s, and so I think that was an important historical piece that I hadn't realized before. She gave us several strategies, some of which you heard variations on the themes, I think, from the other two speakers as well. One about being proactive, one about there being strength in numbers, about really looking at this as an integrated healthcare systems approach, and about being visible. We have to shed that cloak of invisibility. So I think as we then think about some of the things that Joan has shared with us and some of the things that Dr. Broome has shared with us, that again, you'll hear the same themes. Joan shared a lot of information about how we can begin to build the case for what we're trying to accomplish, that we need to seize the opportunities, that there's no better time than the present to move forward. And again, I feel like it could be different paths taken if, in fact, we don't seize the opportunities that have been afforded us, no pun intended, by the Affordable Care Act and by the Institute of Medicine Future of Nursing reports. I think in 20 years we will live to rue that day. She also talked about many ways that we could identify and pull forward content that's really relevant and is surfaced in the baccalaureate essentials, and give us many examples of how that can be relevant to the pediatric education we're talking about. She also gave us a couple of other strategies focused around building a repository of resources in terms of faculty development, and also in terms of a crosswalk with the NCLEX exam questions and getting people engaged as item writers and so forth. And I think as many of you have been, and I have been engaged with NCSBN over the last almost 18 years now that I think about it, in terms of where we've tried to go and some of the issues around NCLEX and the whole concept of APRN exams and core exams, we really need to embrace how can we work to really make sure that we're all in that conversation together. And then Dr. Broome shared with us a lot of things that I think resonated from this, and she identified some of those faculty needs that include things like being more assertive pediatric faculty. Sounds like being proactive to me. About this is more than just shuffling the curriculum and the content around the deck. That we need pediatric graduate faculty to be at the table and having the conversation about undergraduate pediatric education. And we need the OB faculty, if there is such a thing, our psych mental health faculty, our community health faculty, to all be in the same conversation about how are our students learning pediatrics, how are they learning all of that other content. And I think she also then gave us strategies in terms of faculty development. She gave us her vision that includes things like dual appointments and using nurse educators in a team-based approach. So I think that there's a lot of themes that did emerge in common. We'll have to be struggling after you all ask and get your questions answered today with really how to surface those again for you tomorrow morning. In order to really develop a call for action. But I have one question that I'd like to put to the three of them. And And that is, given what you now know and what you've learned about what's gone on in history, and what you anticipate in the future, if there's one thing in the last 20 years that you could change and go back and do over, what would that be?
As a profession?
Yeah, Judy.
Yes, Judy.
Well, it could be personal if you wish, but I wasn't going there.
I can think of some career moves. I can take that on as a profession. Because I think this is really very salient to where we are today. I made quick reference to the end with the clinical nurse specialists in the mid-90s. And at the time I was directing the nurse practitioner programs at Johns Hopkins, all of them. And one of the things that was happening was the CS positions were drying up in the hospital, and those folks were told that they had to come back to a postmaster's program to become a nurse practitioner. Now, these were folks who were, quite frankly, if there was anything seriously wrong with me, I'd want taking care of me. They were the best and the brightest, but they weren't interested in primary care. And they were told either they did that or they lost their positions right across and it wasn't the only place, it happened all across the country because of the financial impact. And so we had a lot of those folks come back, and a lot of them actually left the hospitals. So the hospitals lost a lot of their best and their brightest to go on to something else, rather than creating a different type of career path. The reason I bring that up is that they weren't able to demonstrate that they were cost effective. And we are right there now. We are, and children's hospitals have been a little bit protected against those kinds of things that have happened in the past, DRGs and some of the other things that have come out of Medicare. We're not going to be protected this time under the Patient Care Affordable Care Act. We need to understand better bundled care. Every single nurse needs to know some of the basics of patient safety, how to do a root cause analysis and some of those other kinds of safety tools. And every single nurse needs to be able to find what cost-effective research is, to get the point of what it costs and the clinical efficacy, and when they're looking at nurse-sensitive indicators, not that they're going to go and do the data, but they have an understanding of the bigger picture. So when they're at the bedside making those decisions, they have some sense of how that fits into a bigger picture. And one of the things that I used to ask my graduate students when they were prescribing, I said, what's that cost? They have absolutely no idea. That is not all right for graduate students, but it's also not all right for undergraduate students and staff nurses not to have any idea what this care is costing this family in all kinds of ways. So if I was going to make one change, it's that starting in undergraduate education, moving to the hospitals, and moving to graduate education, as we move forward this program, people get it beyond the child-family dyad and understand that, no margin, no mission.
Yeah. I would agree with Judy. I think, and I would just emphasize that I think that where we're going, we need to be able to prove at all levels the cost effectiveness and the cost benefit of nursing care, and that's not something we've done. But to pick something else, and there's probably many things that I could address, but I think going back to the notion about where we so tried to be so separate between academia and practice, and now we're realizing that we need to partner. And I am not encouraging us to go back to the old training model or indentured servants, that many nurses felt like they were, but rather the need, particularly with the growing, knowledge base and technology, and for a couple reasons on both sides. I think we need practice in academia. They have many of the expertise that they know what's going on. They have the current expertise. They not only have the settings, but they have really the knowledge of what is needed, what we need to know, and how we need to prepare nurses, and can bring that expertise in designing the curriculum, designing the clinical experiences, and teaching many of the classes and the content, or overseeing the research that needs to be done. Vice versa, academia brings the expertise to the practice setting, like Marion described, of overseeing, helping to implement evidence-based practice, mentoring new nurses, I think that it would have moved nursing faster forward in practice, but also it would hopefully speed up the way we can change what happens in academia. So that's kind of a brief overview and really looking at the need for partnering. And as an association, we've gone back and tried to model that. Our task forces, our work groups, our committees now all have practice and academic representation on it, that ones that focus on education and practice. So we're trying to model that at the national level, and it is making a big difference.
I usually rarely struggle with something to say, but I guess I'm thinking that, I really do think that we have struggled many times in our profession, but those struggles were all worth, it just looks to me like they were sort of all worthwhile, and I don't know what I would change. However, having said that, is because we're in such an area, a time of fiscal constraints that, frankly, I think it is the new norm. As a dean, the degrees of freedom are, and in fact, frankly, as faculty, the degrees of freedom about what you really think you need to teach your students is being eroded, I think. And the reason I say that is we have very constrained budgets, and I have a budget that I can totally control. I get 100% of the tuition. But now I think I mentioned, we have 8 master's programs. Probably in 4 years I'll have 4 or 5, because I will not be able to afford the number of certified faculty you have to have in that particular area. For instance, I would not be able to teach in either the PEDS Clinical Nurse Specialist program or the PNP program. I find that fascinating. Actually, I probably couldn't do much of anything as a faculty member anymore, not because I don't know something, but because I'm not credentialed. I still can teach PhD students, I guess, but for now. But it's just, I think that is the one thing I've seen recently, is we've gotten ourselves into much less, we've really become very, very rigid as a discipline, as a profession, in terms of the regulations around curriculum, who can teach, what evidence, what kind of credentialing they should have, and frankly, we cannot afford it in academia. So I think it's even big schools like mine with a lot of faculty are very soon going to have to make a choice. If you can't get a certified pediatric nurse practitioner doctorally prepared to teach that program or coordinate that program, then there's no option but to phase it out. And if you're the only one in the state, and I just faced this, by the way, with our NNP program, I had to phase it out. And it's really, I hope we don't look back 10 years from now and go, oh my gosh, what did we do? Now we don't have enough NNPs, or we don't have enough whatever it is, especially with the burgeoning need for primary care nurse practitioners. You just think, oh my gosh, what have we done? So that's, I think, the only thing, and I wouldn't say I'd change it, because usually I think we do get into things that work themselves out, but this is one I'm putting it together with the finances and the state, decreasing state appropriations. I think we may be headed for a little bit of a rocky road on that.
Thank you very much, all of you, for those comments. I think they were very helpful. Questions from the group? Yes, go ahead.
Marion, you said that you felt things worked itself out. I guess one area I don't feel that has worked itself out is entry level into practice.
My favorite topic. Well, I actually think it had. No, I do think that was that's just the worst thing that's ever happened to the profession. But the reality is, it is, isn't it? I mean, the IOM, we've had this huge enrollment in our RN to BSN. Now, did it help that we put it all online and now it's all statewide and you can take them in 8-week modules, and it's only going to take it? Yeah, I think we did our part. We kind of stepped to the plate and did what we should do. But the fact that the IOM said 80% have to be prepared by 2020, that's going to go. I just find that nurses in practice, now that somebody has said it, especially, unfortunately, the physician, they think that the IOM is only physicians. I don't care what they think, that they need to come back. And frankly, in our area, the magnet hospitals, and we have quite a few systems that are magnet, they're not hiring anybody but baccalaureate prepared. So, and I feel really bad because of, some of the second degree students are going to associate degree programs because they couldn't get into other programs. I feel really bad about that, but I don't care as long as we reach that 80%. And
I'd like to comment and build on what you said, Marion, and that is, I think we were seeing the transition before, but the IOM report and some of the other research that's come out looking at morbidity and mortality rates has really put an impetus behind it. But you're absolutely right. Well, kind of a sidebar, I'd like to, when we have regional meetings and we went around, and it's kind of sad because people kept saying, why are you quoting the Institute of Medicine report and the four competencies that all health professionals need to have, and they said, why are we quoting medicine? And we had to keep telling faculty, it is not just physicians and representatives of medicine. And so it's kind of scary. So that I say that because faculty and people in practice, they don't read, they're not up with their professional organizations, and they don't know really what's going on. So that's the one thing that we need to do, but that's a sidebar, a different issue. But you're absolutely right. One of the issues, not just getting the baccalaureate degree, however, though, is many associate degree nurses don't see the benefit, and they're, wanting to go on and get a master's
they can do
degree.
that, yeah.
So we have to look at various options and ways that we can advance nursing education and provide programs for
well, and
everybody.
we've also had a huge spike in our RN to MSN, and we frankly couldn't make it any easier. You take 2 transition courses and you're into the master's program. Wow. And then they can move right on in through the master's program. So I think that's going to be the future, and and it's our job as academics to make that as seamless and respectful. That's what I think it has become, is respectful of the experience nurses in practice have, and the wisdom that they have from just being around, 20 years in practice. So I think we are.
But we need to count on our practice colleagues to encourage them to go back too, and to create the incentives, not just monetary, but the whole notion that there is a benefit and that they do bring something different back to practice.
Yep.
I'm sorry. Yes, go ahead, Marty.
My question has to do with prevention and the whole initiative on prevention. Our system is built on illness. And if you look at the curricula, most of our content is related to illness rather than prevention. What do you think it's going to take for our healthcare system, our education system, to look at prevention as the key?
Okay, panel, who would like to answer?
Yeah, we can.
She can start.
Well, the fundamental problem with prevention is a measurement issue. It's very hard to measure something that doesn't occur. And if you look at the whole way our payment system is structured, that's how it's traditionally been structured. We also reward bad behavior. Historically, we rewarded bad behavior. If someone gets an infection in the hospital and they had good health insurance, they stayed longer, and we just built out the insurance company. There was no reward for on discharge planning for keeping that person home if they didn't come back through the ER. Now, all of that's changed in the last 2 years, and it's going to change more dramatically in the future. But part of it is aligning the payment structure with preventive health services. The other thing is most of what we've done, so it's sort of like ice skating. We've been skating on one blade, and we all just need, as the initiatives roll out, to be able to change and start skating on the other blade. But a lot of what we do is we just shift monies around, so somebody else takes the burden. So if you take, so we've got to integrate the care better across payers, across systems. And and across people. The last thing is, if you look at the new healthcare law, one of the things, and I'm from Massachusetts, so we're like 3 years ahead. You know, we passed it in '06. So we know what everybody else is going to be facing in a few years. But one of the things, the first thing was access. Now we're really worried about cost, much more about quality and cost. And that's where the prevention piece comes in. Because until you really start worrying about that, you know, your incentives won't be as aligned with prevention as they might otherwise be.
Can I just add? Did you want to?
Go ahead.
If you look at each of our, and I agree, but if you look at each of our essentials documents now that have been revised, updated, totally redone in the last few years, there is a whole section in each one on clinical prevention and population health. And that is really built on a multidisciplinary or interprofessional initiative that grew out of Healthy People 2010 and now 2020, looking at the implementation. So I think the education programs will be having a primary focus and hopefully integrating this and having a major section for all nursing. But I also wanted to comment that I think when we sat around that table and shared information and really talking about what in traditional nursing we focused on and as a role in prevention and population health. So I think we need to step up to the table and take ownership of it to a degree and let people know what the role is that we can have in addressing this. But it is going to hopefully be a part of the curriculum from here on out.
This side of the room, any questions? Yes, go ahead.
So congratulations on your daughter becoming a nurse. I was moved by your story about at 1 to 3 years how she was bored. I feel like I see a lot of nurses like that in my world at Children's in Boston. What do we do with those nurses who are 1 to 3 years out, who are baccalaureate prepared and have the energy? We taught them to think and they are ready to create. What do we do with them right now?
Oh, I have a lot of ideas about that. I really do. I think we say to them, well, isn't this terrible? Here I am, a dean of a school. You don't just have to go back to graduate school. You can go get certified in like LNAC, or you can go, I mean, there are thousands of things out there. If they really, really want to go back to grad school and they know why they want to go and they want to do it, that's fine. But if they're just going because they're bored, you know, what else can we do? Why not? There are a couple hospitals I work with. Actually, Methodist at IU Health is one. They have got money from their foundation, and they have staff nurses who can become magnet fellows. And these small grants buy out their time. They have 20% time. Well, it's 2 shifts a month. So they have to come with a project proposal that meets the objectives of the hospital, et cetera, et cetera. But then they work on that project for 18 months. And they also have to do things like go with the CNO to one of the nurse executive meetings. And so they have to do all kinds of enriched opportunities. And when they do that, one of them came and was presenting, and she did this little study in OB, and I was helping her with the analysis. And I said, so what have you learned out of this? She said, I had no idea how powerful nurses were in this hospital and how they kind of really run the whole thing. I'm like, yeah, how'd you get to that? And she said, well, I'm in all these like executive meetings and I'm hearing things I never even thought about. Nurses end up really kind of having to do all the well, I didn't say no because she's right. But she had always been in her unit, and we have data that shows that nurses think that their unit is that is their world. And their institutional world. They don't think about how that connects, because frankly, we're not paying them to think about how it connects to the larger system. They're there to take care of those patients, and they do a wonderful job. But I think they get to a point, because frankly, I think another thing that staff nurses are facing nowadays, especially in pediatrics, there's a lot of incivility on the part of families in many cases towards our staff, and compassion only goes so far when you're really trying to do the right thing and then you're being treated like you're somebody's maid or something. And I think, or you're the typical, stuff that you're torn about because you're taking care of a child that's been abused, or that's we've all dealt with that. But I think the level of incivility in society nowadays has risen to a certain level, and it's the verbal abuse. I mean, we read about that in emergency departments, et cetera, but I think it's at the bedside in many of our children's hospitals. And I think that wears them out. They're only, 24 years old? I mean, they're not capable of dealing with some of this stuff. And so their way is to get out, go back to grad school. That's a respectable way to do it. So I think just trying to find ways to mentor them, to tap them on the shoulder like you were tapped on the shoulder and say, I want you to work with me on a project. Help to build their confidence. They have so many of them, it always strikes me. I'll give them a compliment on the research council, and they'll go, oh, it was nothing. Well, yes, it was. I mean, come on. Yeah. And you can just see that lack of they're expert clinicians, expert. But when you put them into a new area, they're very, they just don't have the same level of confidence.
I'm concerned because we have this bottleneck a little bit. We have a lot of nurses in the 10-year period or 15-year period towards retirement. And then we have this group of nurses who are ready to sprout. They're desperate to do it. And school is really what's being asked of them to go do, but yet they're ready to seize the moment. And I feel like we have an opportunity to grasp this group, help them remove the invisibility cloak, as Judy calls it, and really let them grow in a place that is very fertile and ready for it. And I think the fellowship idea is a fabulous way to go, but the money is a problem and efficiencies are a problem for us. And I think unless we work together, like this is such an opportunity, all of us together here, to build something on a more national level that helps them change things. There's just so much opportunity, and I hope we can do it. And I think your story...
I would just say I don't know anything about hospital financing at all. I don't know why it costs money to replace them. This sounds really dumb, but I really don't. Every 2 weeks. I know in academia we find ways to cover for each other in class. I'm not so sure it has to be about money, but I think I've read the costs that when you lose a nurse, you're talking thousands and thousands and thousands of dollars. Well, I think you could loosen up a little bit of $2,000 or something, I don't think we make the case to our foundation. Every children's hospital I know of has a lot of money in their foundation. That's where the money should come from. They give it to medicine all the time.
Can I make a few comments on this? First off, I think if we went around the room, and I think sometimes we need to we've had a lot of global discussion. If we went around the room, each one of us could probably list a specific idea of how we might make this work. Some of mine, off the top of my head, is look at the career ladders in the hospital, look at what moves to the next career ladders, identify goals that the hospital needs, build those into the career ladders. So if it has to be some cost effectiveness and go right to the Q's and pillars for quality and safety, whatever you want to use, and build those right in. The second is to get over the lack of confidence issue is have work groups. We have one on evidence-based practice. It's been highly successful. I used to run a publication workshop for staff nurses when I was at Arkansas Children's. That was highly successful. They all benefit the institution because they're doing the work of the institution. A third one is and this would be easier, Marion, for you than it would be for us, but have university classes that are held on the campus of the hospital. So you have a cohort then who can be doing group projects that benefit the hospital. So you got to figure out how to double dip. It's all about Boolean logic here to me. Now, another is with the nurses who are working, particularly in ICU, have them follow some of their clients back out into the community so they can understand what the long-term impact is and bring that back to the care they're giving. And we're going to need that more and more as we're looking at bundled care. We did a study on what it costs to replace a spica cast. Now, why are most spica casts need to be replaced? Because of dirty diapers. That's strictly a nursing function, and I won't share with you how much it cost, but it blew, it's in the literature, but it was $11,000. Think about it, 4 professional fees and an OR fee. That's in almost all cases, that can be prevented. That's a huge nursing function. There's lots of those things that you can identify in whatever specialty area you are. And one last thing, and this blew me away when I was preparing this presentation. I went on, because it was so unlike academia, I'm talking strictly to practice now. Nursing is invisible on the hospital websites. Absolutely invisible. I go to a university website, I type in the university, I type in nursing, a URL pops up, I hit. I have no idea what Marion's real title is or her email is, or any of her faculty, their name pops up, I can hit a button and I can email. Could I find for some of the children's hospitals any of the history of nursing? Heavens no. I couldn't even find the name of the CNO for a lot of the children's hospitals today, right now. So when you're talking about that foundation money and what nurses are doing and how they're improving the system, I don't know how you make this happen in your institution, but when you click on that website, rather than seeing how great the cardiac program is, see what the nurses have done for pain relief for children or outreach. You know those rotating things they have all the time? Not on the internal website, that's fine, but on the external website, and have a link so it says nursing. So you hit nursing, and then you can get to the people you need to talk to. Because I couldn't find my way through almost any children's hospital's websites to find the people I wanted to talk with. And when you talk about invisibility, take a look. Sorry, that's my bandwagon for today.
Well, so let me just throw two more things out. I also have a daughter who's 26 and a NICU nurse who did decide also to go back to school. But one of the things that I think I hear from her a lot is she and her young colleagues are very interested in volunteer activities, and they'd like to volunteer outside the country. She just came back from a week in Haiti, and she didn't stop talking for 3 hours after she got off the plane. But I think one of the things we're doing is an injustice, I think, to the young people is, at least in this part of the country, they have been raised in high schools that they were expected to do a certain number of volunteer hours and get engaged in the community and try to make a difference and so forth. And so they have that in their mentality, and they get through college and they may have a little bit of it there, but then they're out there, they find that they're getting comfortable in their roles, and they're looking for ways that they can continue to do that. And they like to travel, they'd like to be able to figure out how to do that, but they'd love to travel to Cambodia or Haiti or anywhere and be able to combine the two. And so if we can figure out ways to help them tap into that energy, I think that would be another thing that gets them. But the other pitch I will make is we don't have nearly enough young people in any of our professional associations. And so if they can take any of that extra energy that they're feeling bored and put it into joining any professional organization and get engaged in that, that's another way I think that they can be routed. Yes.
Marion, I liked your comment about having the undergraduate and graduate faculty get together to talk about PEDS content, a strategy I'm taking back to UAB on Monday morning. But I reflect back on when I was in my doctoral education and thinking about what my major professors told me to do during doctoral studies was focus, 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 get narrow, become an expert in it so that your name is known in this area. Be an expert, be known, know who the leaders are, and then you go into academia, and they go, "What can you teach?" And I go, "Well, I can teach this, but I can't teach that because I got to focus, so I can get that R01." Fortunately, I was a maverick and didn't really do that, and still see myself as a generalist today. But if we're thinking about reaching the needs of us in academia, we're particularly for those doing the PhD, again, that narrow focus. What should we do different in our doctoral education? Because we're preparing our future education.
Well, I think actually in the document, is it 10, the pathway to excellence for the PhD, I think there were some substantive changes in that spoke to a little bit more exposure to education, but leadership as well. You know, I think some of that socialization, actually, it's fine. You got to get done, and a dissertation has to be focused. But when they come to us, first of all, I am very clear about the fact that if 1 out of 5 of you who come to, and we are number 9 in NIH funding, so we're pretty research intensive, but 1 in 5 actually really wants to do it at that level. So I say to them, we've got a big mission here. We have lots of things you can do. If you really want to go the NIH route, we will support you to do that. But we have a lot of other opportunities. You still have to do enough research to get promoted. But we allow people to get promoted on teaching excellence. That has another whole set of grants and scholarship and all that you have to do. But what we need are good citizens. And I think it's up to every individual to figure out, I had to figure it out pretty early because my topic was pediatric pain and they didn't have a course in pediatric pain. I mean, just couldn't. They didn't even have a pain course. Now they do at places like Iowa. But, I couldn't. So I had to figure out family development, pediatrics, the practicum, pediatric practicum. You just really had, I think everybody has to do that in their own way. But when you focus too much, I think you run a couple of risks. One is that you can actually study your way out of a problem. It's not a problem anymore, and society's moved on, unless you sort of really keep yourself a little bit broader than not. But also decide what your real unique contribution's going to be. And it may be in research at that level, but it may be developing the best PNP program in the country, or it may be being the international, assistant dean or one of the faculty that really carries the international agenda. Most schools have a lot of different opportunities and missions. So I think that is a pretty clear message, but I certainly don't try to reinforce that unless they really think they want to really get that big ROI.
I would just add that we hear this from our deans and directors of programs, that when new graduates of PhD programs in particular come out, that they come to them and say, well, I'm prepared to do research and I don't want to teach, or I'm not going to teach undergraduates. Mm-hmm. And we hear that all the time. Mm-hmm. And so I think we need to, whether it be in our PhD programs or even in our DNP programs, I think we need to begin this whole culturalization and thinking that you're being prepared at the top of your profession in a terminal degree, and you may be prepared in a particular area of expertise and a more narrow focus. But if you choose a faculty role, then you really need to think broader and be able to think about not only developing your skills as an educator, but also then, what you're going to teach in your contribution to the program. So I think it goes both ways. You do need expertise in an area if you're going to focus on a particular area of practice or research, but if you're going to choose the faculty role, we need to prepare people to think, and know that this is going to be part of their role to teach broader.
Other questions? Okay.
Marion, when you were talking about the joint appointments between Riley and your university, I just think in my what I'm hearing from some of my colleagues, I mean, it's all lean and mean. We're running lean and mean. We're doing more with less. And we've had some back and forth with the universities, but is there a way for us to swap, in terms of, or how do you all accomplish that?
We only have one. She's starting in January, and it's one of our PhD grads. It's not at Riley, actually. It's at Methodist, which is one of the other 3 IU health hospitals. And she graduated, I think, in May with her PhD, and is the wound ostomy. She runs the wound ostomy program. She's an adult nurse practitioner. But what she really wants us for, which is truthfully what most people who come from practice want us for, is the research. That's what we do. And she also wants to start a certification program out of our CE department for wound ostomy nurses. So I'm taking the risk here, frankly, but I'm willing to do it just to make this start. And so we're buying out 30% of her time from Methodist Hospital because she does direct care and they bill for that, I guess. I mean, some of this I'm a little shaky on, but I'm trying to remember. But so they'll have to get somebody to see those patients. Then we are pretty clear about the expectations. But she's going to work with one of our R01 funded faculty to put in R21 and then to go in on an R01. So we have a 3-year contract. And hopefully we will meet her needs to be on a research team. She will develop this certification, which we will make money on if we do it right. And here's the beauty, here's our need. We need more preceptors for our A&P students. And because we're running into terrible problems now, I think everybody is, with getting enough preceptors. And so we've asked her to make sure that she does whatever that, for 5 of them. And so to me, it is a risk. And not everybody's willing to take that kind of risk, but I think it's. The person that she's working with is thrilled, the NIH-funded researcher, because she wants to move into this area. So she's happy, and she's one of my really stellar faculty. So I'm glad about that. We can expand our CE offering, and so there has to be a lot of win-win for everybody, even if it is a risk. But I think there has to be money exchange. Our faculty consultants who work on the EBP councils, I have to pay them a $3,000 stipend a year. I don't have to, but everybody everywhere is killing themselves. So I put that into their travel account, and then I bill the hospital. The hospital's fine with it. I think they know that's a pretty good deal, actually. And so they're happy they get 2 more trips that they don't have to, pay for themselves, and no taxes. And the hospital's happy. So you just have to kind of find a lot of different, whatever works is my motto, as long as it's legal, of course. But I don't want to be on the front page of the Indy Star for anything illegal. But so I think you just have to come up with an idea and then keep talking it up until somebody bites. But she's our first, so I really can't say I have a lot of, outcomes related to that.
I just want to comment on that. And this was the question I was going to ask, which is, I think key, whoever brought up the word partnership, as we move forward with education, we really, one of you had said this, we sort of drifted apart. Medicine never drifted from clinical, but we drifted academics and clinical, and somehow they didn't meet. And we really have to come back together. And exactly what Marion's saying, there's a lot of creative things going on out there, but we're talking about them in education. We need to be talking about them across education with our practice partners. So, for example, designated education units. I don't know if any of you have those. That's a very hot thing right now. We're doing something similar to Marion, where we have a couple of staff nurses who are master's prepared that we're paying 20% of their salary so that they can facilitate more of the preceptoring of the undergrad students, that sort of thing. We actually have a medical center where we have a joint research office. So I'm the Associate Dean for Research over the College of Nursing, but also at the hospital. And so we do a lot of partnering there. But one of the things that I've discovered from talking to the previous folks is a few years ago, there was a lot more energy and a lot more freedom to do this. And in fact, I think it's always tied into magnet status right now, where people were supported to do research. It was really, I've never seen such burned out people in my life. I thought the faculty were bad until I started working with this research council. They just look exhausted. And so we're all trying to do it, but it's a challenge right now. But my big message is we need to be doing these partnerships, and we've got ideas, but we need your ideas too, because, you're going to have a whole different set of ideas on what to do in these things.
Yes, go ahead.
Yeah, I have a couple of observations and kind of want to hear what everyone's reaction to it is. After 30 years of academia, now I'm in the hospital setting. So I'm looking at the hospital with new eyes, basically. And I think there's a couple of things that contribute to nurses feeling bored, feeling unfulfilled, being viewed as just necessary evils, and not wanting to continue their education. They don't want to go to the workshops that are offered. They don't see this as a career, but as a job. And one of the things I noticed is that the nurses have name tags with only their first name on it. I think that is so paternalistic and demeaning and unprofessional that it's like, why is this? Well, they always say, well, because that way the patients won't know who I am and they can't stalk me or whatever. It's like, oh, for heaven's sake. Physicians don't have that, pharm techs, social workers, everyone else in the hospital, even the food service people have their name, whole names on their name tags. The other thing is this idea of clocking in and out. That seems to me that if we really want nurses to be professionals and treated as professionals, they can't be treated as hourly workers. And my first experience graduating from nursing school was kind of like Marion's. I went into the Navy, and there was no clocking in and out. We got a salary. We got our hours posted. We showed up. He didn't show up. There were consequences. I mean, big ones. And you know, it just seemed then, my next job after I got out of that was a women's hospital where I had to clock in and out. I kept forgetting for like the first 6 months because I was not used to doing that. I don't think nurses see themselves as professionals, and I don't think that other people see them as professionals, and for what it's worth.
No, you could listen to Jerry Springer, and people on Jerry Springer's show will say they want to be pediatric nurses, and without any concept of what's required. Right. So that's a good point.
So, I don't know.
Anyone
If it will
up here
ever
want to
change.
tackle that?
That and tackle it.
I just wanted to ask Jan why you're watching Jerry Springer.
I do have a reflection that I'd be interested in having you provide some remarks on. One of the things that's evolving in graduate education, particularly for advanced practice, is now we have recognized that gerontology and adult care are now to be merged, and that the competencies are shared, and that it's an adult in the aging process. And one of the things that we talk about when we talk about pediatrics is we talk about children and families. And so the corollary in the graduate arena is a family nurse practitioner. And one of the things that we've heard from a lot of areas is that their family nurse practitioners are particularly highly valued in rural settings because they need advanced practice nurses that can do the lifespan and so on and so forth. And since in the graduate arena, we're sort of looking at this population focus, maybe adult gero, and people are beginning to envision family pediatrics or family children. If that is to evolve, which many purport to be headed in that direction, if that is to evolve, how will that be reflected in the undergraduate curriculum? We talk about family care, parenting. Those are really important content areas. Should we, families are very critical to schools, parental involvement. Parenting is something that we are hearing is just gone as an area that needs to be taught. People need to know, just like you need to learn how to balance the checkbooks, you need to learn how to be a parent. And we're not focusing on that, but pediatric nurses often own that content and perhaps should. Should we be family nurses? And adult gero nurses?
All I know is what I hear from students. I actually have a master's in family nursing from the University of South Carolina. I had no intentions of doing family nursing, but they didn't have pediatrics, so that was the closest thing. I never did anything but pediatrics after I finished. And that's what I hear from students. They choose that FNP because they want to broaden, have all the possible job opportunities, but they either say, I would never work with children or I will only work with children. And I'm afraid that, frankly, it'll be less time for the chronic acute. I suppose I could go either way. I think, how will it affect undergraduate? They don't communicate now. I don't know how it would, frankly. I mean, I don't see a lot of that. I do know there are some curricula. I think Georgia State's maybe one of them. There's several that I've been trying to push at Indiana, but nobody's biting. They pick up a family like I say, we should pick up one in downtown Indianapolis. And it should be interdisciplinary team and of undergraduates and then all the other areas. And then they're going to follow them for 2 years. It has to have a child and it has to have an older family member. Not living in the same house necessarily, but in the family. And they have to go to the healthcare system when they visit, and they have to do checks and all this kind of stuff. And I've told the other deans that we would each have to take our own cohort as student, a team, and follow them for 2 years. That's where it stops, actually. But I just think that you could get rid of about 28 competencies the first month if we would think that outside the box. And the PR for Indiana University in Indianapolis would be priceless, as they say, because we would be meeting needs that nobody else is meeting. So in that case, you would have to have a curriculum that supported family, family theory. You'd have to have it lifespan. It would be really interesting to see. I hope that doesn't happen.
To build on that, and I think that Marion has addressed the issue, and that what you're talking about, and I don't think it would have that much impact on necessarily the breadth of the content, but the way it would be taught on the undergraduate. And I agree. I think we need to think differently. But you're talking about family theory, family concepts, team-based care, interprofessional communication care, a lot of, that stuff that should be in the undergraduate curriculum and could be taught very differently. When you started in the example that you used in advanced practice nursing and the various populations, as we all know, at least in most situations, that the family nurse practitioner, that's not just meaning that they care for families. It really means across the lifespan practitioner, somebody that's prepared to care for somebody from very young through the very old. So I think it's semantics, but you're talking about two different things. So you're not just talking about dealing with families and family theory and being able to deal with issues, but you're talking about somebody across the lifespan. So families. But I guess what I'm saying is that I think a pediatric nurse practitioner or somebody dealing with, either undergraduate nursing or a pediatric nurse practitioner has to have that content, and focus on families and caring, because I don't see how you can prepare somebody to provide one-on-one care for children without dealing and understanding families and grandparents and other issues. So I wanted to clarify the difference between semantics and across the lifespan, somebody that just cares for anybody across the lifespan, and really understanding families. And maybe put the bug in your ear, maybe you need a specialty in family or family care or even care of children for individuals who are FNPs and other people who deal with across the lifespan.
Okay, well, one last question. Can we do that? Sure. Okay. Yes, go ahead.
I just have a... Can you hear? Okay. So I've always been a pediatric nurse. I am an FNP. And the reason why I chose that course of study is because probably 25% of my patients who are now adults, but they have childhood diseases, and now they're living longer. And as a pediatric nurse practitioner, I would not be able to continue to care for them in the community. And I am licensed to care for them in the community, and probably 25% of my patients are over the age of 23 who go out, who are in the community with, diseases that many times just cannot be transitioned to the adult world. And we would love to have them be transitioned to the adult world, but they don't want to go. Their parents don't want them to go, and many of the adult practitioners don't want to treat them. Sorry, so I think there is a role.
Okay, yes, absolutely. Go ahead.
I was just going to say, I find this as an interesting conversation. I'm at the beginning of parenthood journeys. I have a 3-year-old and then I'm expecting one. But I think, going into it, you think, well, how could I not be prepared for this? I'm a pediatric nurse. I've only worked in pediatrics. And I will tell you that it's an entirely new skill set. And if you want to start talking about curriculum to focus on healthy children and healthy, raising healthy children, talk to new moms, because that's all we talk about. Like, I'm very aware of the environmental threats to children. That is not something that was at all on my radar prior to this. So I think, yeah, it's a conversation worth having, and if that's where we think we're going, there's a lot of people teaching that content who are not necessarily pediatric nurses, but they're people who became passionate about motherhood and have found their way into family centers and are kind of serve as community resources. But they model in a lot of ways, I think, nutrition, we talk about growth and development, all of that kind of stuff that we're talking about here is really captured in an arena that's separate from pediatric nursing, at least in the experience of myself.
Could I make a follow-up? One of the things to bridge what you were saying and also to bridge what Marty was saying about prevention, and I also know I'm stealing Marion's thunder here, which has been a passion for hers, but I really think should be a driving force both in nursing curriculum and practice, is the whole idea of health literacy. And that not only captures when you were talking about family, my head was going with all the what ifs. What about the family where it's a single person and their 2 cats? What about the family where it's an older couple and they don't have any kids? What about the gay families and the lesbian families who are trying to adopt kids? What about families where one family member has died or is dying, or all those other parameters, which if we're really talking about children, you can use children as the focus and then talk about the whole family. But to bridge some of these discussions, and we start talking about health literacy from a prevention model as the center, and then when we fail with those kinds of things, and culture most certainly goes in that, then we can move into the other arenas of acute care and chronic care and other risks that we didn't ameliorate that maybe we could have, and so forth. So maybe we need to think about it not in terms of what unit of the population we're going to look at, but going back to a public health model of primary, secondary, and tertiary prevention. Just a thought.
I'd like to thank everyone on the panel for all of their great comments this afternoon. Let's give them a big round of applause. So I hope that you'll ponder some of the comments that you heard this afternoon and bring those, surface those again tomorrow morning.